move on to our second part of the session, and that is going to be introduced by Kumar from Clinical Immunology. And we have some presentations from medical students, which is very exciting. So Kumar.
Thank you. So we have two presentations which cover student-selected component electives. And the first presentation is by Tanja Chowdhury on behalf of herself and Chris Lai, who's now a FI1 doctor in Oxford. Each presentation will be 10 minutes. Tanja will be talking about a scoring system to help decision-making in deciding whether patients with antibody deficiency should be treated with immunoglobulin replacement therapy or not. And the second presentation is by Kyriakos. I can't see him in the audience list. I will do the presentation if necessary on the retention of protective antibodies to exanthematous viruses in patients with primary and secondary antibody deficiency. Tanja.
Can you see my slides okay?
Thank you.
Yeah, okay.
Yeah, that's perfect. Thanks, Tanja.
Okay, hi, so my name's Tanjia, and as Dr. Kumar said, I'm a fifth year medical student, and today I'll be presenting the project that I did for my year 4 SSC. So I did this alongside Chris Lai, who's now an F1, and we did this under the supervision of Dr. Kumar. And so our project was titled The Evaluation of a Scoring System to Guide Initiation of Immunoglobulin Replacement Therapy in both primary and secondary immunodeficiency patients. So, as I'm sure you're all aware, supplies of immunoglobulin replacement therapy are constrained and likely to remain so for the foreseeable future. This is in part due to the difficult nature of its production, as it relies on plasma donation. Coupled with this, there's also an increased usage in various medical specialties, such as neurology, dermatology, and of course, immunology. More recently, the COVID-19 pandemic has also impacted immunoglobulin supplies due to a decreased number in plasma donations. Interestingly, there was also a ban put in place to prevent locally donated plasma from being used in the UK, which meant the UK had to import all immunoglobulins. This ban was recently lifted in February 2021. So this increasing demand and short supply has served as the basis for this project, which is to evaluate the efficacy of a clinical scoring system which can be used to guide decisions in the initiation of immunoglobulin replacement therapy. So there's both an economic and clinical need to ensure that immunoglobulin replacement therapy, IGRT, is only given when necessary. And that's because once initiated, patients are often on IGRT long-term or even for life, which means that they require regular transfusions that can impact their quality of life. So in order to ensure that this decision is made accurately, immunoglobulin assessment panels, or IAPs, have been implemented across the UK. So a scoring system to guide clinical decision-making when prescribing IGRT may also be of use in order to further standardize the process of IGRT provision and thus reduce strain on immunoglobulin supplies, and also as a tool in order to compare prescribing practices between different centres in the UK. So the scoring system that we adopted was devised by our colleagues at Mount Sinai and was published in this paper by Cunningham Rundles in 2013. And they applied the scoring system that they devised retrospectively to a cohort of 65 patients with primary immunodeficiency, of which 46 were recommended to start immunoglobulin replacement therapy by immunology consultants, and 19 were not recommended. So the scoring system is based on both patient laboratory data and clinical history, which are scored separately, and the cumulative score is the lab and the clinical score combined. So this paper found that their scoring system effectively discriminated between patients that were and were not recommended immunoglobulin replacement therapy. And this was when we looked at the laboratory score and also the cumulative score. So if we look at the scoring system itself in a bit more detail, in this scoring system, patients being considered for replacement therapy are scored across various categories, with a higher score meaning a stronger indication for starting immunoglobulin replacement therapy. So these categories can be divided broadly into laboratory and serological markers, such as immunoglobulin titers and vaccine responses, as well as clinical markers, which we derive from clinical history and examination, as well as non-serological respiratory examinations, such as spirometry or high-resolution CT. So, for example, if a patient has had pneumonia 5 times in their lifetime, they will get a score of 5, whereas some scores were more sort of yes, no. So if they've ever had sepsis in their clinical history, then they would also get a score of 5. However, if they've had a splenectomy or any splenomegaly, then they would get a score of 3. So you get at the end of the scoring, you get a total score which comprises of a laboratory score, which is out of 25, and a clinical score out of 53. So the total combined score should be out of 78. So we, in our project, we retrospectively applied the scoring system to both primary immunodeficiency patients, which was also done in the Mount Sinai paper, but also we applied this to secondary immunodeficiency patients, and all of these patients were considered for immunoglobulin replacement therapy at the East of England Immunoglobulin Assessment Panel between February 2019 and December 2020. So these patients were either accepted or rejected for immunoglobulin replacement therapy. We then further categorized them into those that had primary and secondary immunodeficiency. So overall, we assessed 97 patients, of which 33 had primary immunodeficiency and 64 had secondary immunodeficiency. And this table just shows exactly the demographics for each of the cohorts. So the total laboratory and clinical scores of those accepted or rejected for immunoglobulin replacement therapy were then compared using a 2-sample two-tailed t-test, and we also plotted receiver operating characteristic curves. So overall, our results demonstrate that the scoring system successfully differentiates between patients approved or rejected for immunoglobulin replacement therapy, regardless of whether they have primary or secondary immunodeficiency. And this table sort of summarizes all our results, but I'll go and talk about them in turn. So if we just think about the combined cohort, so regardless of if they're primary or secondary immunodeficiency, if we look at the combined cohort, we can see from this plot, this scatter plot and curve, that the total score is successful in differentiating between those that were and weren't accepted for replacement therapy. And we see the same results when we look at individually, if we look at the primary immunodeficiency cohort and the secondary immunodeficiency cohort. Interestingly, if we interrogate the results a bit further, so looking at just the primary immunodeficiency cohort, we see that this cohort is being differentiated and discriminated using their laboratory scores rather than their clinical scores. And conversely, we see that patients with secondary immunodeficiency are being discriminated on by their clinical scores rather than their laboratory scores. So I think this quite nicely demonstrates how the emphasis of clinical decision-making shifts depending on the etiology of the immunodeficiency. So as I mentioned, patients with primary immunodeficiency were being weighed more heavily. The decision was being weighed on the laboratory scores, whereas those with secondary immunodeficiency, the decision making was weighed more on the basis of the clinical scores. And so using this information, we proposed some decision trees. So we can see in the top right, if we have a patient with primary immunodeficiency, we would first look at the laboratory score and see if it was high enough to initiate immunoglobulin replacement therapy. If not, we'd then go on to look at their total score to see if that can help with the decision making. Conversely, if we have a patient with secondary immunodeficiency, we'd want to look at their clinical score first to see if it reaches the threshold to start replacement therapy, and if not, we'd want to look at the total score to see if they could start replacement therapy. So in terms of the project that we undertook, so we've presented it at the European Society of Immunodeficiency, and that was something that Chris did, and we have a few proposed next steps for where we could take this project. So we could potentially generate scatter plots for each category that we had in the scoring system, and that might be useful to assess the utility of each category. We could also potentially add new parameters with the aim of improving the ability of the scoring system to differentiate between patients. We could also try to potentially replicate the study at different centres across the UK. This would help to further increase numbers, but also help to compare IGRT provision at different practices between regions. And also we could potentially create a scorecard pro forma to be filled in when seeing patients who are to be considered for immunoglobulin replacement therapy, and that would help to automate further data collection. So that's the end of my presentation. Thank you for listening, and I would really appreciate as a student if people could maybe scan the QR code and give me some feedback on this presentation.
Well, I'll start with one piece of feedback, Tanjir, which I think was very, very clearly and lucidly presented. So well done. I've got a couple of opening questions, which may be for you or maybe for Kumar, but how much does immunoglobulin therapy cost per patient?
So for an average adult, it can vary between depending on their weight-based dosing, it can vary between £12,000 a year to 25 to 30,000 pounds a year. This is for immunoglobulin replacement therapy. The doses used for immunomodulation are much higher.
Thank you, Kumar. That's very clear. And I hadn't actually taken in the BSE ban. Worldwide, how many cases of BSE transmission were there through immunoglobulin?
None. It was a knee-jerk reaction, but there have been studies and calculations done to say that the chance of transmission are very vanishingly small.
Okay, that's intriguing too. Now, without coming to the work you've actually done, Tanjir, so I think you've assumed that the panel that makes these decisions makes perfect decisions.
Yeah, that is an assumption that we make in the project, and that's why I think it's really useful to sort of look at different regions and have the input of different consultants and different IAPs as well.
And so I think looking at your plots, the question I had, for both you and Kumar is, if you look at the let's take the patients who received replacement therapy, but whose scores were actually rather low, and we're at the lower end of the group that actually didn't get the therapy. Kumar, when you look at those patients, do you think that the decision may have been wrong, or was there something that the panel was taking into account that isn't there in the scoring system?
So the way the decision making and monitoring is done is you initially make a decision by a multidisciplinary panel discussion, and then these patients are monitored clinically and reviewed at least once a year by the panel, and they will look at efficacy and also the replacement levels that were achieved. So there is an iteration of decision making, and sometimes patients treatment is stopped or their treatment is increased. So that is, I think, the main utility of this method is not to have an algorithm driving your decision making, not to delegate clinical decision making to that, but to apply this year on year to see whether there is a change in practice. That is one, but equally importantly, to compare performance between centers. So that is, I think, the most useful way to apply this system.
Thank you. Are there questions from members of the audience? I don't want to dominate the questions too much, but then another question I had, Kumar, is what percentage of the people who perhaps should have immunoglobulin replacement therapy get it at the moment? I mean, so what I'm getting at is, are there, I can imagine that if you're admitted to Addenbrooke's with an episode of sepsis, it's quite likely that someone will raise the question as to whether there's an immunoglobulin deficiency. But it might well be that if you went to a different hospital, the chance of that happening would be lower. Or it may be that there are people who just don't end up in hospital but get repeated courses of antibiotics from their GP.
So the panel that functions at CUH covers the whole of East of England, all the hospitals within the region, and decision making is reviewed at this panel. So there is standardization that way. And when we have audited the performance, the immunoglobulin decision making before the panel became active, so in other words, the historical patients, we found that there was a greater chance of over-treating rather than under-treating.
Oh.
So there were patients who really did not justify immunoglobulin replacement therapy or receive therapy, and a number of such patients have been taken off therapy.
Very interesting. I mean, I think we all
and
know
of course,
that avoiding over-treatment is crucial.
Yes, and of course there is an appeal procedure, and the way we would function is we would transfer the appeal to an independent panel so that they can look at it afresh.
Okay, well, thank you very much, Tangier. Please do use the QR code and give Tangier some feedback. It's actually one of the main things that the medical students tell us is that they want more feedback. But well done, Tangier. And now I don't know whether we have Kyriakos with us or whether a slightly advanced medical student, Dr. Kumar, will be doing the second presentation.
I will, unless I hear otherwise, I will share my screen. These slides were prepared by Kyriakos, but I'll talk to them. Let me just give me a moment to share my screen. I hope you can see the screen.
Yeah, we can see the screen. It's not on the full screen view. It is now. Brilliant.
Right. So the aim of this study was to look at the retention of protective antibody responses to exanthematous viruses. By that I mean measles, mumps, rubella, and varicella in adults who develop antibody deficiency, either primary or secondary, as adults. So, I don't need to tell this audience what exanthematous viral infections are. Of course, smallpox is another example, which is eradicated now. these diseases, apart from smallpox, chiefly occur in childhood, but can have severe consequences if adults get primary infection as well. And the graph on the left side show the reduction in the incidence of MMR of measles. MMR vaccine was
Super, thank you so much.
Sorry, and the panel on the right side show the peaks and troughs that occur when the uptake of measles MMR vaccine varies in the UK. Next slide, please. Oh, sorry. So I wouldn't expect you to read this. What Kyriakos has done is he has reviewed the literature on the right side for healthy adults, the retention of protective antibodies to measles, mumps, and rubella, and on the left side, the limited number of papers that address the retention of protective antibodies in individuals with secondary antibody deficiency, mainly with HIV or transplant recipients or leukemia patients. And there are only 2 points I want to make: that a large majority maintain the measles and rubella immunity, while mumps immunity declines in a larger proportion of adults. And furthermore, in the small number of studies in secondary immune deficiency, again, the pattern is repeated. So why did we do this project? So, well, if you listen to me and not look at the slide for the moment, the main point is that if you develop exanthematous viral infections as an infant who has either HIV, neonatal HIV or severe combined immune deficiency, they will die of these infections. On the other hand, adults who develop even AIDS as an adult, or person with secondary or primary immune deficiency as an adult, do not develop serious infections with these exanthematous viruses. So what we want to do was to confirm this by looking at protective antibody responses against these viruses in patients with primary and secondary immune deficiency, and also if we were able to identify people who had declining immunity, then you could target protective measures in these individuals. So the method was to select 2 cohorts of 50 patients each of adults with either common variable immune deficiency, which is a primary antibody deficiency presenting in older children or adults, or secondary antibody deficiencies. And the European Society of Immune Deficiency criteria was used to confirm diagnosis of common variable immune deficiency in each patient. And the data that were collected were the immunoglobulin levels at diagnosis, IgG levels at diagnosis against measles, mumps, rubella, varicella, and tetanus. Post-immunization IgG antibody levels were also identified against 13 pneumococcal serotypes, as well as type B Haemophilus influenzae. Now, the 2 groups had the following characteristics. You can see in the top panel the number of patients for whom data was available, and in the lower panel the course of the secondary immune deficiency. The large majority studied had been treated with rituximab, a B-cell depleting therapy, and there were few other patients. So this is the main data slide. The bars, the vertical bars, represent the percentage of individuals who are seronegative for either the pneumococcal serotypes, Haemophilus influenzae type B, measles, mumps, rubella, varicella, and tetanus. The blue bars represent patients with secondary antibody deficiency, and the red bars represent patients with common variable immune deficiency. Now, it is not surprising that 100% of the patients with common variable immune deficiency had no protection against the pneumococcus or the Haemophilus B, because this is part of the definition. To make the diagnosis, you immunize the patients and check whether they have a protective response afterwards. Now, you can see that far more patients with secondary and with common variable immune deficiency were lacking in protective antibodies, but the large majority of patients in secondary antibody deficiency were retaining antibody responses against measles, mumps, rubella, varicella, and also tetanus. So when one compared using statistical methods, it was found that for common variable immune deficiency, the total IgG level mean was lower compared to those with secondary antibody deficiency. And CVID patients, as I mentioned, had a high chance of having poor undetectable IgG responses to all the specific antibodies that we studied. And across both groups, IgG against exanthematous viruses were more commonly maintained in contrast to antibacterial IgG. So what are the implications of this study? The first point is, as you know, protective antibodies against exanthematous viruses in countries like the UK are mostly acquired from the MMR vaccination. A small proportion for chickenpox, of course, almost 100% acquired from infection during childhood. So it is a live vaccine or a live or an infection with a virus that induces protection. And also, the contrast between the maintenance of antibodies against viruses, exanthematous viruses, against the loss of protective antibody capacity, competency against bacterial polysaccharides mainly, so, indicate that the physiological pathways that result in generation of these antibodies are different, and therefore studying this in greater detail and granularity is likely to provide us with information that may help us to enhance the immunogenicity of vaccines like the COVID vaccine. So I think this is worth looking at. Now, the weakness of the study, of course, is that we were using the antibody tests that the virology, clinical virology department use here, and we use their cutoffs in deciding whether the person had protective antibodies or not. Now, this may hide the fact that some of these patients may have antibodies, but that are not neutralizing. So what we hope to do with the help of James Saventharan is to look at, to take the measles antibody responses and to ask the question, are the epitopes of the protective antibodies which are directed against the relevant surface components of the measles virus the same or different in patients with antibody deficiency versus healthy individuals? So that is how we hope to extend this study. I will stop here, and there are a number of people, the whole clinical team contributed to this study, and I will hopefully answer any questions that we have.
Thank you very much, Kumar. While we're waiting for people to so please do type your questions into the chat, everyone. Kumar, can I ask a peripherally related question, which is, in these groups, how effective is the COVID vaccine, and is there a difference between the different COVID vaccines available in the UK? And what strategy have you advised for them in terms of vaccination?
Okay, so I can answer incomplete. I can provide incomplete answer because we don't have full convincing data. Now, indeed, colleagues like James Hoyenther are showing this in detail from the preliminary data from him and also presented from other groups. There are surprisingly, there are a proportion of patients with primary and secondary antibody deficiency who appear to have a measurable IgG response to the COVID vaccines, all the COVID vaccines. Now, however, I think James has found in a small number of patients with primary antibody deficiency, although they may produce antibodies, they are non-neutralizing. So this is, certainly merits the type of further investigation that is happening. And it is, of course, here we are concentrating on antibody responses. There's less measurable data of the contribution of T-cell responses. But what I have to say is that, if you take the lessons from patients with immunodeficiency, patients with primary antibody deficiency, with rare exceptions, do not have increased morbidity and mortality from exanthematous viral infections. In contrast to patients with combined or T-cell deficiency. So, antibodies appear to be the most important component.
Very interesting. And we've got a question from Nick Matheson. Are there well-defined immunological correlates of protection against these viruses, be they humoral or cell-mediated? And to what extent are severe viral exanthems a feature of CVID? I think you may have just answered the second one, but the first one, are there well-defined correlates?
I've looked at the literature. There are hardly any reports that I could identify of severe infections in patients with antibody deficiency. Of course, once they get immunoglobulin replacement therapy, they are passively protected. Now, so in relation to correlates, we have to go back to the classical publications, and without further study, I can't off the top of my head answer to you how the protective correlates are worked out. But I hope there's somebody from clinical virology who might be able to answer this more specifically. But I was going on the sort of WHO published data on this.
Thank you. And there's so if anyone is able to answer that, perhaps type it into the chat. And Andrew Lever, presumably none of the patients had previously had IVIG and received specific antibodies from this source. So how did you get over the problem that they might have had passive antibodies?
So I can answer that categorically. So what happens is, it is part of our routine workup that when patients are initially assessed for antibody deficiency, we take a serum sample, store that, and that is when we determine their antibody levels. So, and I can categorically answer for the cohort that we studied, none of them had intravenous immunoglobulin or immunoglobulin of any sort before before the studies were
Brilliant.
done. Before.
Well, I don't think there are any more questions, and time is up. So, Kumar, as the second medical student presenting today, I think we can also feed back to you that you're coming on very well, and we hope that your exams at the end of the medical course go smoothly. And
thank you. I was extremely well supported by Efrosini Krani-Klotzers, who provided the epidemiological help.
Brilliant. So thank you very much to all our speakers, and thank you to the audience for a very interesting set of presentations. Thank you, everybody.